Pregnancy, Part 3. We're now going to start talking about some pregnancy complications, and I'm not going to spend a great deal of time on these because they're not things that you will have to be dealing with as an LPN, but they are things that you need to at least be familiar with briefly. Hyperemesis gravidarum is basically a lot of vomiting when you're pregnant. It's not the same thing as morning sickness. It's defined as persistent nausea and vomiting, and it results in weight loss, dehydration, and electrolyte imbalances. It's treated by ruling out other causes with fluid replacement, with antiemetic drugs, dopamine antagonists. Ectopic pregnancy is where the conceptus is implanted anywhere outside the fallopian tubes, but 95% conceptus is implanted in the fallopian tube, but it can be implanted anywhere else outside of the uterus and outside of the fallopian tubes. But 95% of ectopic pregnancies do occur in the tubes. There's numerous causes, but basically the zygote is prevented from traveling to the uterus as it normally would. We treat it by controlling bleeding if it's severe. Do nothing if the conceptus is being resorbed into the woman's body. Medical therapy can be administered to prevent cell replication, in other words, to kill off the embryo with a medication such as methotrexate and all resorption into the body. Surgical removal of the conceptus is also a possibility, and removal of the tube if the tube is damaged significantly. Hydatiform mole is also known as a molar pregnancy. There may or may not be a fetus present. Symptoms include hyperemesis gravidarum. Again, that's a complication of normal pregnancy, and that's why other causes should be eliminated. Treatment: women should not become pregnant for that year. There is the hydatiform mole is removed, and then they have the follow-up with the HCG for a year, and mom should not become pregnant because it can interfere with those HCG levels. It is a pregnancy loss, and it requires the same psychological considerations as with an abortion. I've talked about in prior lectures about abortion being the same term as miscarriage. It is the appropriate term, but miscarriage is sometimes a little bit easier to hear. A spontaneous abortion is the termination of the pregnancy without action taken by the woman or another person prior to 20 weeks gestation. Many spontaneous abortions are unrecognized because they occur so early in the pregnancy. Again, the appropriate term is abortion, but miscarriage is generally used with a client. 10 to 15% of pregnancies will end in miscarriage, and all types of miscarriages can end in infection. The threatened abortion is one that, again, is just threatened. It's not necessarily going to happen, and it can be prevented. The first sign is vaginal bleeding. So again, all vaginal bleeding should be explored. The cervical os will remain closed. The os is the opening or the mouth of the cervix. Abdominal cramping may be present. So think about the interventions that you as a nurse would perform. If a woman comes in, we know she's pregnant and she starts having bleeding, we need to know the history of the gestation, the onset, duration, and amount of bleeding, and understand that most women, when they're describing the amount of blood, it's going to be, you're going to think they're hemorrhaging from their description. So try and get them to equate the amount to a known size, like is it dime size or quarter size? Is it once an hour? Is it every 5 minutes, etc.? Is the bleeding accompanied by any discomfort? Does she have psychological support? We encourage them to limit sexual activity, bed rest, and encourage fluids. These can be diagnosed by ultrasound and by HCG levels. The inevitable abortion, we may need to do a dilatation and curettage or a D&C if the bleeding is excessive. A vacuum curettage is to clear the uterus if natural process is ineffective or incomplete. Nursing interventions with an incomplete abortion are going to be to stabilize the mother's cardiovascular state, administer blood products and IV fluids as necessary, and possibly do a D&C if the gestation is less than 14 weeks. We don't want any products of the conception to remain in the uterus. It is a prime site for infection. A complete abortion, nursing interventions will be no additional intervention is required unless bleeding or infection do occur. Rest for mom and monitor for any further bleeding or pain, and have her avoid sexual intercourse until after a follow-up appointment. A missed abortion. This is where the fetus dies during the first half of the pregnancy, but it continues to remain in the uterus. We will do an ultrasound and assess fetal heart activity, check HCG levels, do a D&C or a D&E, vaginal prostaglandin, or possibly Cytotec to help mom pass the products of conception. DIC and infection are complications. DIC is disseminated intravascular coagulation, which can cause significant bleeding risk for mom. A recurrent spontaneous abortion is defined as 3 or more spontaneous abortions. Primary causes of recurrent abortions are believed to be genetic or chromosomal abnormalities or anomalies. Potential Rh incompatibilities can also be a cause. So there is an examination of the reproductive system for any anatomic defects, a genetic screening for chromosomal factors, and these are based on the cause of the pregnancy loss. If mom just has a weak cervix or an incompetent cervix that is unable to remain closed and hold in the products of conception, a cerclage can be done where the cervix is actually stitched closed to help maintain the pregnancy. If a mom has frequent abortions, then we also want to make sure that we are assessing the Rh of her blood and making sure she is getting RhoGAM if necessary. Late hemorrhagic conditions of pregnancy would be placenta previa, where it is an implantation of the placenta in the lower uterus. The placenta is closer to the cervical os than the presenting part of the fetus. And abruptio placentae, which is separation of the normally implanted placenta before the fetus is born. This occurs in cases of bleeding and formation of a hematoma on the maternal side of the placenta. So we'll go into a little bit more detail of these in labor and delivery. These are just some diagrams showing the placenta previa on the left side where the placenta is covering all or part of the cervix, and on the right side, the separation of the placenta from the uterine wall. Preeclampsia is a condition in which hypertension develops during the last half of the pregnancy in a woman who previously had normal blood pressures. She may develop some renal involvement, which will show proteinuria. The pregnant client may experience generalized edema. The only cure for preeclampsia is the delivery of the fetus. It occurs in 5 to 10% of all pregnancies. Nursing interventions include frequent rest periods and maybe restricting activity, daily weight, a urine dipstick test for protein, monitoring the diet, elevating edematous extremities, monitor the blood pressure, do a fetal assessment, antihypertensive medications, anticonvulsant medications, and seizure precautions. And if preeclampsia is allowed to progress on, we may see some tonic-clonic seizures, and then it goes from preeclampsia to eclampsia. The HELLP syndrome is also a very serious complication of pregnancy where mom has hemolysis, elevated liver enzymes, low platelets, and this is a variant of gestational diabetes. Diabetes mellitus. Again, if you remember me stating earlier in one of the other lectures, during pregnancy there is an increased resistance of cells to insulin, especially in the second and third trimesters, and there's an increased speed of insulin breakdown. So women secrete extra insulin to maintain the carbohydrate levels during pregnancy. And if a woman cannot increase insulin production, it will result in hyperglycemia. Hypertension is diagnosed as chronic hypertension if it precedes a pregnancy or a woman is hypertensive prior to 20 weeks gestation. 20% of pregnant women with chronic hypertension develop preeclampsia. Hypertension will actually age the placenta at a more rapid rate. In other words, a 36-week gestation placenta may actually look more like a 40-week gestation placenta. It begins to have what we call infarcts and calcium deposits, and it's not allowing appropriate nutrition and oxygen transfer to the fetus from the mother. It may result in an intrauterine growth retardation. In other words, the fetus is not as big as it should be. Maternal hypertension does encourage the fetal lungs to mature more rapidly, so that is the one positive. Nursing interventions are to continue antihypertensive medication if currently on, to avoid diuretics, and regular fetal surveillance to make sure the fetus is tolerating the pregnancy well. Nursing interventions for RH incompatibility. Once again, if mom has miscarriages, it's very important to make sure that RH incompatibility is not an issue. So we'll do a blood type to determine her RH factor on that initial visit. An indirect Coombs test will determine if they are sensitized as a result of exposure to RH positive blood. If it's negative, then it's repeated at 28 weeks. If positive, RH immune globulin or RhoGAM is administered at 28 weeks and again within 72 hours after birth if the woman delivers an RH positive infant. Very important because those antibodies can cause her to actually miscarry or abort future infants if she is RH negative and she has an RH positive baby.